I think that the neoadjuvant chemotherapy principle is being adopted in the United States. I think nationwide we have about 50% of patients, up to 50% of patients that undergo neoadjuvant chemotherapy. It's similar in my division. The Europeans, I think, are ahead of us, where the percentages are even higher in some countries. And we might, and I wonder what you guys think, at some point say that all newly diagnosed advanced ovarian cancer patients should have neoadjuvant chemotherapy.
So we'll get to that question, because in secondary cytoreduction, the answer is probably surgery and help. I think we'll get to that. But in your guys' worlds, what percentage of patients after going through these complicated algorithms get neoadjuvant chemotherapy?
We are definitely more than we used to be, but I would say we are still probably 60 to 70% primary cytoreduction.
Really?
Wow.
And I think that, and Dr. Dorigo may be right, or I might be right. I really believe in primary cytoreduction. One of the two groups is going to have kind of a, we like to say, a come to Jesus moment when the TRUST study is finally done. Because that's the study, I hope, that's going to answer this question.
Tell us what that study is.
So the TRUST study is mainly being run in Europe. There's a few US sites, I believe. And it's randomizing consecutive patients to either primary cytoreduction or neoadjuvant chemotherapy.
But they have bigger knives.
But a number of things. You have to agree to offer this study to consecutive patients. Now, the patients can opt out, but you have to agree you're not going to select.
Right.
You're not going to cherry pick, number one. Number two, the only way you could enter the study is if you had proven that you could operate, that you could get to R0.
What do you mean, they're surgeons that can't operate?
They're surgeons that aren't going to get someone to
That's
R0.
aggressive.
And
That's aggressive. You mean they have better judgment?
I think that may be true, or
Depends on the situation.
Or not. I think it depends on the situation.
It might be poor judgment.
And I think we don't like to say that out loud, but if you have portohepatous disease, can you get that out? Sure you can if you have a hepatobiliary surgeon helping you in the OR. So I think there's different radicalities, different thresholds that people have, and they had to agree, they had to prove that they had achieved a certain level of R0 resection to even participate on the trial.
So Tom, you practice in a very metropolitan area. What do you think is an appropriate rate of neoadjuvant chemotherapy?
I have a pattern that's probably very close to yours right now. I'd say probably 60% of ours are getting primary cytoreduction and about 40%. I would say 5 years ago I was probably 10% neoadjuvant. Now I'm 40%. So I've moved a long way towards that. I think that the SGO issued a nice statement about this that looked at the literature, which is a good reference. And then the other thing I would say is, the concern with neoadjuvant, a couple things are interesting, right? You decrease the death rate, which is low overall, but you decrease mortality, surgical mortality. You decrease surgical morbidity, cut it in half. You more than double the optimal cytoreductive rate, and you more than double the R0 rate, getting to no gross disease.
That's why we do
which
it.
should convert to a better outcome, but it has not.
It does convert to a better outcome in select patients. So it's all about patient selection.
But it doesn't.
In all comers, no.
It doesn't in terms of survival. So the survival's the same, and that is the concerning part of this discussion, is that if you look at the survival from both CHORUS and from EROTC study, and the EROTC study had particularly large tumors, greater than 10 centimeters. But CHORUS had more of a normal real-world data set. Both of those, the median survivals are approximately 29, 30 months. And if you look at contemporary series from major centers with aggressive cytoreductive programs, those median survivals are 45 to 50 months. So that makes it concerning. Yes, there's cherry picking going on, et cetera, right. But that's the concern, and that's why people are concerned.
Again, it's the hardest decision we make.
Yep.
So, and that's why we're having such a spirited discussion. Yeah. The criteria are unclear, okay? But to the point, ASCO has said, the last thing you want to do is have the patient seen by a medical oncologist start chemotherapy without having a formal consultation with the surgeon. Yeah. So I think that's really the take-home message.
It's an important part of this.
Yeah. And unfortunately, that happens way too often.
Right.
And that's a message I think we have to get out there.
Thank you for that.
In that context, Brad, Dr. Fagotti out of Italy is going to present at this meeting the Scorpion trial, which is actually designed as a superiority study. The hypothesis is that neoadjuvant chemotherapy does better, just like you just suggested. And we'll see what the study shows based on the abstract. That doesn't seem to be too much of a difference.
That's right.